Good afternoon. It's so nice to see you at our HTRC telehealth series. It's good to see some returning and some new faces, so thanks for joining us today. We're especially excited. I know our Oklahoma HTRC partners joined today with Tim Davis, so thanks so much for joining and for many of you from joining across our region. I'm Evelyn Nelson from the Heartland Health Resource Center. Today, we're excited to continue Dr. Martin's HTRC education series focused on telehealth billing, coding, and policy. Just a few reminders. This session's being recorded and we'll share it afterwards through our HTRC website. Your microphones have been muted. We're a smaller and mighty group today, so please unmute or use the chat to send you questions and to talk. You can test out the chat by typing your name and organization so we have a good idea who's here. We appreciate you keeping your camera on if you're able to, so it feels like we're talking to a group, and it's a-okay to eat your lunch. That's awesome. Your completion certificates will be emailed. It's important to sign on with your first and last names so that we can identify you and provide the certificate. If you have any challenges with renaming, just remember it's the 3 dots on your Zoom screen, and then you'll be able to type in the name. So with no further ado, I know Rochelle has wonderful information for us today. Let's get rolling. Just a reminder, Dr. Martin is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. She's worked as in-house consult with healthcare organizations ranging from assisted living, physician practices, ambulatory surgery, hospital, and health systems. And especially during the pandemic and post-pandemic time, she really has a lot of expertise in telehealth, and we're excited to learn more about Quasi Telehealth Services today. So thank you, Rochelle.
Absolutely. Thank you, Dr. Nelson. Well, I will jump in quickly too. I think you're passing the baton quickly because, you know, I always go right up to that 1 hour mark and we want to make sure we get through all of the information. Today's topic we're talking about is the first of actually 3 different sessions in what I call quasi telehealth, where we're kind of stepping out of those bounds of the really technical and prescriptive definition of telehealth, the way Medicare defines it, with originating site limitations, limitations on the sites of service, limitations on distance site eligible professionals, and into services that are similarly provided in settings other than an in-person face-to-face that you may or may not know you could actually be reimbursed for in different settings. So today we're going to be focusing on communication-based technology services. And in July and in August, we're also going to have sessions on another category of what I consider quasi telehealth services called care management. Management of patients' chronic conditions, transitional care management from an acute care setting to other post-acute care settings. And then one focused on a particular care management service called remote patient monitoring, where you're actually following patients, maybe blood glucose or blood pressure or weight or pulse ox outside of an in-person face-to-face visit. So make sure you join those sessions too and watch your email for the dates and times and links to those sessions. Before I jump into today's topic of communication-based technology services, I did want to pause and just do kind of a quick check on where we are with the public health emergency from the Federal Department of Health and Human Services and the state emergency declaration orders, because we are now in a phase of kind of wind down, hopefully, knock on wood, of the public health emergency, where we're starting to see some of the policies that were interim or temporary policies start to revert back to the pre-COVID public health emergency rules. And these are much like when we went into the public health emergency and states, governors, created executive orders declaring a state of emergency in individual states at different times, and each state's emergency status and executive orders and government agencies relaxed different statutory and regulatory requirements, many of those with respect to telemedicine and telehealth, different requirements at different times in different ways. And now we're going to be seeing kind of the opposite of that. We're going to figure out which of those policies are going to continue to be extended, even though the state emergency declarations are being rescinded or allowed to expire, versus some of those that may remain permanent as opposed to going back to pre-COVID rules. So with that said, at the federal level, the Federal Department of Health and Human Services Public Health Emergency, the big one that we have been referring to as the PHE, that really dictates a lot of the flexibilities and waivers for telehealth that we have been growing accustomed to over the last year or so, was recently extended through July 19th of 2021. So that one renews every 90 days. However, I've got a link a little bit further in the presentation. The Department of Health and Human Services has sent a letter out to the state governors suggesting that at a federal level, they expect the public health emergency will likely continue through the end of the calendar year. And that's important. If you think back to a month or so ago, if you joined our session on changes for telehealth in 2021, a lot of the changes will remain in effect through the end of the calendar year in which the public health emergency ends. And it sounds like Health and Human Services is sort of suggesting or alluding to the fact that they may try to align the end of the public health emergency with the end of the calendar year. So we're dealing with one set of dates at a federal level, which may be great. The other thing that's important in that letter to the governors, and again, I have a link to that in here in just a few slides, is that the Department of Health and Human Services also said they will give the governors 60 days notice prior to the expiration of that. So right now it's extended through July. That's another, month and some change. We have some reasonable assurance that it's likely going to be extended for at least another 90 days after that, because of the federal department's commitment to notify states with a couple of months notice. Now, Oklahoma, right after one of our last sessions, the governor in Oklahoma rescinded the emergency declaration status. So that was on May 5th. In Kansas, as of right now, it looks like it's set to expire June 15th. So here in just a couple days, we'll be watching for that. In Kansas, remember, as with many states, there are some flexibilities that were a result of the emergency declaration executive order for telemedicine. And there were emergency licensure provisions to get providers licensed in the state of Kansas much quicker than they otherwise would be able to, and to be able to provide telemedicine services to individuals located in our state when they otherwise may not have been able to do that, absent those executive orders. So we definitely may have a lot of activity here in the next 30 days between Oklahoma and Kansas. I will say in Oklahoma, just in a quick check in the last couple of days, it doesn't look like any major telehealth announcements have been made, especially with the Medicaid program and some of the flexibilities that they offer. But we're going to keep watching that. In Missouri, the most recent that I've seen is that the emergency declaration has been extended through August 31st. So it's a little bit more in line with what we're seeing at the federal level. And we'll just wait and see as we get closer to August if that will be allowed to expire, or if it's maybe rescinded even sooner than August 31st in the interim. All right, so that's kind of where we are with our public health emergency. I'll try to point out at different points during today's session rules that apply regardless of whether we're in a public health emergency or not, and then a few rules specific to these communication-based technology-based services that are unique to the public health emergency and that offer greater flexibilities than we will have when the public health emergency ends, at least with the rules as they stand today. So again, my quasi telehealth, that's not a technical term. Medicare doesn't call it that. That's just kind of my layman's reference to services that are not provided in person between providers and patients that are happening outside of those in-person visits. Yet they don't fall under the Medicare telehealth, telemedicine benefit. They are Medicare services that Medicare covers, just like other non-face-to-face services, but they're not technically telemedicine. That's good, I think, from an access perspective, because we are not limited to providing these to patients who are in rural areas outside of the public health emergency. We don't have a lot of the same restrictions that we have for Medicare telehealth services. So within this kind of umbrella term of quasi telehealth services, the one, again, that we're going to focus on today are communication technology based services. And I'll explain what I mean by that. There's really two or three services in particular. And then in the next couple of sessions, we're going to cover care management in general, like chronic care management, transitional care management, and then also a whole session dedicated to a relatively new category of service called remote patient monitoring that has gotten a lot of folks excited about the reimbursement opportunities and the care opportunities for those. So let's jump into communication technology-based services. You'll see this abbreviated CTBS if you're looking through Medicare payment policy materials. And again, it's not technically telehealth, the way telehealth is defined by Medicare, with all of those particular restrictions on the way that Medicare pays for telehealth services. Generally, these communication technology-based services are only allowed to be provided to patients who are established patients of a healthcare provider. And we talked a couple of sessions ago about what that means to be new or established. So an established patient generally is one who has seen that exact provider who would be delivering the CTBS service, or another provider of the exact same specialty and subspecialty in the same group practice in the last 3 years. Sorry for the background noise if you're hearing the dog upstairs. We must have a delivery driver here. During the public health emergency, though, the CTBS services can be delivered to new patients. That is a temporary flexibility that's allowed only during the public health emergency for these particular services. One thing that's important to keep in mind is we have to get consent from the patient before we deliver a communication technology-based service. Consent, though, that's required for these services, Medicare doesn't require that be a separate form. So it's not necessarily adding a lot of paperwork to the registration process. That can be verbal consent. So it can be documented in the progress note that the provider would be recording when they're providing this service. That could be a checkbox if you're developing some kind of documentation template saying that you got the patient's consent to deliver a communication technology-based service. It can be done by other staff. It doesn't have to be the physician or non-physician practitioner who may be delivering these services. It could be an office staff member. It could be a nurse in the practice who's getting that consent. And it can be verbal. It doesn't have to be written consent. There's nothing that says that you have to get the patient's signature to be able to provide these services. Really, the essence of that consent is that the patient still has deductible and coinsurance responsibility for these services under the Medicare program. And because they're not face-to-face where you could maybe infer that the patient is consenting to the service and understanding that there would be a bill for these services, Medicare explicitly wants us to get consent from the patient so that they know that there's going to be a bill and charges, and they're agreeing to that financial responsibility that they may incur. But the timing of that consent isn't critical. It could be prior to the service. It could be during the service itself. The communication technology-based services are listed under the Medicare program as sometimes therapy, meaning if you are a physical therapist, occupational therapist, speech therapist, or delivering therapy services, and you add therapy modifiers to the codes for CTBS services, they can count as therapy benefits. Now, I keep saying CTBS services, but I haven't really told you what I mean by that. So the two key services that fall under this category are what are called virtual check-ins and remote evaluations of recorded images or recorded video that are received from patients. So let's talk about what those services mean a little bit more. I'm going to start with the virtual check-in services. So these services were designed as a way to communicate with the patient via technology. That may be email, that may be messages through a provider portal, or other technologies. The key here, Medicare is not prescriptive on what type of technology it is used, just any communication technology that's used to provide these services. So unlike telehealth that requires audio, visual, real-time, live two-way interaction, that is not a feature of CTBS services. And with virtual check-ins, the intent is to have a way to connect with a patient to determine if the patient needs to be seen via a true telehealth service or maybe in person in an office or other setting. So this, the best example I can think of for this, for me as a parent, has been with my pediatrician's office for my kids, right? They've got the cough, they've got the maybe a fever, they've got a rash. So we can have a check-in to say, hey, here's what's going on. And the provider can say, no, let's just get the humidifier, give them some Tylenol, let's wait and see, or determine that we do need to come in for a visit. And that's from my personal experience where I've seen this used. That it can be a billable service under the Medicare program that you could be paid for. And we'll talk about how this works under the Medicaid programs in just a few minutes as well. In the COVID era, this could be used when a patient's calling in with maybe some respiratory symptoms and you determine should the patient come in, what are the pros and cons, the benefits versus the risk of that potential exposure, and whether they need to have a COVID test or whether they need to kind of watch and wait at home. It's also been used in a post-op type environment to determine a patient's likelihood for maybe an infection after surgery. So lots of different uses for this type of service, and it's not limited to any particular specialty. So the physician, MD or DO, or a non-physician practitioner, so typically that's going to be nurse practitioners or physician assistants, they have a non-face-to-face check-in to assess whether that patient's symptoms or condition would require the patient to have a visit. And if the answer is no, so this virtual check-in is not related to a service that has happened within the previous 7 days, and it doesn't result in a visit in the next 24 hours or the soonest available, if you don't have anything available in 24 hours, then you could bill for a virtual check-in service and be paid for that service. So the virtual check-ins, they're payable by Medicare under the physician fee schedule. So if you are a physician clinic, a provider-based outpatient department of the hospital that bills both the facility and the professional fee, but also if you're an FQHC or RHC, these are paid outside of the all-inclusive or your prospective payment rate as well. And I'll talk about that just a little bit more in a few minutes. Again, these are not preventive services. So the patient's deductible and coinsurance do apply, which means we have to get the patient's consent. And again, that can be verbally, that can occur during the service, and it doesn't have to be from the physician or the non-physician practitioner who's delivering the communication technology-based service. So I want to look at the codes here. There are two primary codes that we can use for these service. And I've highlighted a couple of pieces of the description for these codes that are very important. So they're brief services. Brief is just referring to the amount of time we spend on this virtual check-in. So these initial codes describe 5 to 10 minutes of discussion with the patient. Now, we've discussed in previous sessions this, there's a rule when we're assigning procedure codes like CPT codes or HCPCS codes like these, that when you see a time in a code, it typically means that you can report that service so long as the amount of time you spend providing the service passes the midpoint. So let's say, for example, these codes said 5 minutes of medical discussion. The rule generally says that if you passed the midpoint, if you provided 2 minutes and 31 seconds of medical discussion, that would be enough to report the code. However, these two codes are an exception to that rule, and where it has a range of 5 to 10 minutes, 5 minutes is a minimum threshold that you would have to meet to be able to report these codes. What that means then is you have to make sure in the documentation, whether that's a progress note from a physician or the non-physician practitioner or some other healthcare professional, that they're recording the total amount of time that they spent on this virtual check-in service to be able to support billing for the service and being paid. So that's the brief part, referring to how much time we're spending. Then the difference between these two codes is who is providing the service. So in G2012, this is being provided by a physician or qualified healthcare professional. Typically, that's going to be a nurse practitioner or a physician assistant, but it could be any healthcare professional who is eligible through their licensure to provide an evaluation and management service. When they are doing the virtual check-in, G2012 is the code that they would use. And again, you may have auxiliary staff, nursing staff, office staff helping with this consent process, but in terms of the medical discussion, it's a qualified healthcare professional eligible to bill E&M services. Then we've got the piece that this check-in, it cannot relate to a service in the previous 7 days. If we saw a patient 7 days ago for, let's say, hypertension, and this virtual check-in is to determine if there needs to be a visit related to maybe bronchitis or COVID type symptoms, those aren't related. Right. So the condition or the complaints at issue are important in distinguishing whether this virtual check-in is related to a previous service. So if it is related, we cannot build a virtual check-in. And then also it cannot lead to the decision to have an evaluation and management service within the next 24 hours or the soonest appointment that you have available. If it does, we don't build a virtual check-in. That's just part of the eventual evaluation and management service that we eventually report. I will add an asterisk to that, though, that if we spend a substantial amount of time on the virtual check-in piece, considerably above and beyond the average time that we end up spending on that later office visit within 24 hours or next soonest available. We may have some options to account for this virtual check-in time through extended service or prolonged service add-on codes on top of the code that we report for the office visit. So moving down to the second option that we have to report for virtual check-ins is G2251, which is provided by someone who is not eligible to report evaluation and management services. This is a code that could be reported by physical therapy, occupational therapy, speech therapy, other qualified healthcare professionals who don't bill E&M. Right, so this would not fall under the evaluation and management category of services. Otherwise, it's the exact same as the other code. It just depends on who is providing the service. One thing I want to point out with these services is that right now the valuation is the same regardless of whether it's being performed by a qualified healthcare professional or a non-qualified healthcare professional, because Medicare in their fee schedule said that the work is really substantially similar. So in my mind, if it makes sense then, if you're going to provide virtual check-in services, to think about the qualified individuals within your practice who could deliver a virtual check-in service, reserving physician, nurse practitioner, or physician assistant time for those who need true telehealth or true in-person visit services. These particular codes are not covered by Kansas Medicaid or Missouri Medicaid, and I didn't see them on the Oklahoma Medicaid fee schedule. However, I've got links here to the fee schedule. I've got a link to a Kansas Medicaid bulletin and a Missouri Medicaid bulletin, and the Kansas Medicaid and Missouri Medicaid bulletins suggest it's not that the service is non-covered, it's that they want us to report it with different codes. So if we're doing a virtual check-in for an individual who has Kansas Medicaid or Missouri Medicaid as their primary insurance, this bulletin that KMAT published suggests that we could report that with a code for a telephone visit with place of service 02, indicating that it's being done via telehealth. Or alternatively, that we could report this using an office visit type code with a place of service 02, describing a telehealth place of service also. Now in 2021, we had a new virtual check-in code that was added. If I go back one slide, so remember this is 5 to 10 minutes, and that 5 minutes is a minimum threshold. We have to have at least 5 minutes of discussion with the patient documented. And Medicare added a new payable service for virtual check-ins that last more than 10 minutes, so anywhere from 11 to 20 minutes of medical discussion for services provided by a physician or other qualified healthcare professional. So this is an alternative to G2012 when the amount of medical discussion takes more than 5 to 10 minutes, somewhere between 11 and 20. And you can see here what the rates are for these services. This is coming from the Medicare physician fee schedule. I believe this was the Kansas data file. And there are 2 rows for this code. The one that has a blank in this very first cell is the rate for a non-institutional setting. So that would be like your regular physician office setting. If you would report a place of service 11 on the CMS 1500 claim form when you're billing, that's your rate. Versus the one with the hashtag, that's the rate for a facility-based CTVS service. So that's what you're going to get paid for this 11 to 20 minute virtual check-in if you are a provider-based outpatient department of a hospital or other facility setting. Okay, so I said there's 2 really main types of communication technology-based services. The virtual check-in is one, to determine the need for the patient to have an in-person visit. And the other type is a remote evaluation of either images or video. So this is another great one. Again, as a parent, these are so helpful when I have a pediatrician who could look at a photo of the rash, right, or the the scratch or the cut to see if we need stitches. Do we need medicine? Do we need to come in? Or a video, maybe the sound, my son was just in the pediatrician's office for kind of a croupy sounding cough, and we're trying to decide if we need a COVID test. Is it croup? Is it pneumonia? Is it something else? So that the video could be something we could transmit to the pediatrician's office. And that's really what these services are designed to pay for, to capture. And we have two options, again, for these services. One, for remote evaluation of an image or a video when the evaluation or the assessment is done by a qualified healthcare professional, someone who can bill for an evaluation and management service, versus a healthcare professional who's not eligible to bill for evaluation and management services. I think of physical therapists, speech therapists, occupational therapists as examples of that. Otherwise, the description of these services look exactly the same. So video and or images, meaning it could be both or it could be one or the other. Interpretation with follow-up. And Medicare clarifies that by follow-up, that doesn't mean necessarily follow-up in the office. That could be a phone call to the patient to say, I got your image, I got your video, here's what I think, or maybe send me more videos or more images to better assess the patient's condition. And then I'll also highlight the word in bold, established patients, because again, outside of a temporary flexibility during the federal public health emergency, we would expect both virtual check-ins and these remote evaluations to only be provided to established patients. So patients who have seen that particular professional or another provider in the same group practice in the last 3 years. And if a patient doesn't meet those criteria, they're considered a new patient, which right now we can deliver a remote evaluation to, but after the public health emergency ends, these will go back to only being available to established patients, at least under the rules that we have in place today. So good news, if you are an RHC or an FQHC, this is one of the few services that are non-face-to-face that can be paid in addition to and outside of your all-inclusive rate or your prospective payment rate. For RHCs and FQHCs, we can't make it simple on you though. We've got a different code that you report than a regular physician office may report. So for RHCs and FQHCs, Medicare created G0071, and this describes either a virtual check-in or a remote evaluation of images and videos. Whichever of those that you're providing, this is the code you use. And the payment rate that you would get as an RHC or an FQHC takes the rates for those two types of services, averages them, and that's the payment rate for G0071. For rural health clinics and FQHCs, you can bill for the remote evaluation or virtual check-in using G0071 on the same claim as other services, like your all-inclusive rate, your RHC visit or FQHC visit, or it could be billed alone, absent another service. The revenue code that you're going to use on the claim is 052 with the qualifier for the type of visit there at the end. Okay, another type of communication service is an EVisit. And the example I think of with an EVisit is more of, like, think of a patient portal communication where you're sending messages back and forth. Okay, so it may not be for the purposes of determining whether you need to come in. There may not be an exchange of images or videos during that email or that patient portal conversation. But if you have it's called an online digital assessment or an e-visit, that's something that Medicare would pay for as well. So we have 3 different options for these e-visit codes, depending on how long the total time the healthcare provider spends on the e-visit service. And so one thing to note here where it says 5 to 10 minutes, that again means a minimum of 5 minutes have to be spent in total. It doesn't have to be consecutive 5 minutes. It could be throughout a day, or it could be over the course of several days, as long as a minimum of 5 minutes are spent. Which also means if you're delivering e-visits, you need to document how much time you're spending on those communications, both reviewing what comes from the patient and then communicating back to the patient through that digital assessment. So again, that's the cumulative time over a 7-day period. And the idea is that because this is not a live interactive conversation the way a telehealth visit would be, it's asynchronous. So you send the message, you may wait several hours to get a response, and you're going back and forth potentially over the course of 7 days, with the idea that that communication or that assessment would generally be concluded within a 7-day period. For these digital assessments, they're initiated through a HIPAA compliant secure platform. So email, plain email through a regular email account is generally not going to be sufficient, but the most common example where you may see this is going to be messages through a secure portal. It could be email if you've got a way to secure those messages in a HIPAA compliant way. So encryption going back and forth between the patient. And Medicare doesn't prescribe the type of technology, just like they don't prescribe the type of communication technology for a check-in, just like they don't prescribe a type of technology for reviewing images or video. They're kind of leaving that open-ended, recognizing there are so many technologies available even today, and probably even more will be developed in the future. They're giving providers that flexibility to select the one that's most appropriate for you and your patients. Now, while the patient's problem or condition or symptoms that are being discussed during these digital evaluations or these e-visits may be new to the patient and may be new to the provider, the patient still generally needs to be an established patient of the provider or practice. So they've seen that provider or another provider of the exact same specialty in the same group practice in the last 3 years. The time, the 5 to 10 minutes or 11 to 20 minutes or 21 or more minutes of time begins as soon as that communication is received and the provider begins to review it. So if you receive a message at 8 o'clock in the morning, but the provider doesn't get it and open it and start reviewing it until 10 o'clock, we don't count that time between 8 and 10, right? We're only counting the time spent actually reviewing it. And again, very important that the providers remember to document their time. That has to be documented to support these codes. But the time that you spend and the time that you document that can be included in in which code you are selecting for your e-visit service can include everything from a review of that communication, going back and reviewing the patient's chart, looking at allergies, medical conditions, family history, those types of things, looking at other progress notes, creating a plan, creating an assessment, generating orders, documenting orders. That can be prescriptions, imaging, lab tests, whatever that may mean, and then communicating back with the patient. And all of that can be counted in the time that the provider is documenting and using to select their e-visit code. And again, all over the course of a 7-day period, doesn't have to be consecutive or even on the same calendar day. These are weekly totals. Now, if we have multiple providers that are involved in this e-visit service, so let's say we have a provider take that initial communication, look at it, may not be the patient's primary provider, and goes to the patient's usual primary care provider within the practice to kind of coordinate a response. Their collective times will be used to determine how much time we can count to report these services, but we don't report two separate EVisit services. Within 7 days of an evaluation and management service, if the EVisit is related to the same problem as the evaluation and management service at some point in the last week, then we don't report an EVisit code. That post-visit work would be included in the payment for the previous evaluation and management service. But if this EVisit is happening within a week of a previous visit and it's unrelated, it's for a different problem or an unrelated problem, then we can report the EVisit service either 98970 or 71 or 72, depending on the total amount of time, with a modifier 59. And that modifier 59 is going to communicate to Medicare that this EVisit is unrelated to that claim that you received within the last 7 days for a different or unrelated problem. What will help to even better justify that this EVisit is separate and should be separately payable is making sure that the diagnosis codes that you report on the claim and that you link to these EVisit services are different and distinct from the diagnosis codes that you linked to the previous office visit. For these EVisit services, these communications through typically through patient portals and messaging applications, non-physician practitioners like social workers, psychologists, PT, OT, speech language pathologists can provide these services also. They are not evaluation and management services. They fall under the medicine section of the CPT book, and that allows other types of professionals to provide them, deliver them, report them, and be paid for them. So this is, again, a table from, I believe this was the Kansas Medicare physician fee schedule to show you the payment amounts as we progress from 5 to 10 minutes, 11 to 20, or 21 or more minutes. And again, the lines where it's blank in this first column are for non-facility settings, like a regular office visit, place of service 11, versus the hashtag would be a facility-based setting, like a provider-based practice that's considered an outpatient department of the hospital. And you see a slightly lower rate when that's the case. Okay, phone visits are another type of communication technology service that we've seen a lot more of in the last 12 months. There have been codes in the CPT book for phone visit services for quite some time. It's really only been in the last year or so that we've started to see payment for them, primarily as a product of the COVID public health emergency. So I want to talk about the codes themselves, which may still be covered by commercial insurance companies, even outside the public health emergency, and then some things to think about as we're starting this kind of unwinding process of the COVID flexibilities, to be thinking about if you're currently providing phone visits and relying on those flexibilities. Just like the EVisits, we have 3 options for a phone visit service from a physician or other qualified healthcare professional. So these are evaluation and management services, the 3 codes you see on the screen now, meaning the professional, the qualified healthcare professional delivering these phone visits and talking with the patient on the phone has to be someone whose licensure allows them to deliver an evaluation and management service. Your PTs, your OTs, your speech therapists, social workers, we'll talk about what they would report in just a moment. It's by phone. You see the same kind of time increments, 5 to 10 minutes, 11 to 20, 21 to 30. And again, right here, that 5 minutes is a minimum threshold. So when you're doing a phone visit, you have to document the visit, just like nurses would document call notes with a patient, or hopefully they're documenting those conversations with patients. But you have to remember to document the time to be able to support these services. Similar to our virtual check-ins and our remote evaluations, these phone visit codes cannot relate to an in-person or telehealth evaluation and management service in the previous 7 days, they don't lead to the decision to have an in-person or telehealth evaluation and management service in the next 24 hours or the soonest available appointment. But that word related that you see here, just like we just talked about, if this phone visit is for new symptoms, different conditions than were discussed during the previous evaluation and management service, then you could still report a phone visit, even if it's within 7 days of a previous visit. But it has to be distinct and separate from that previous evaluation and management. Otherwise, it's included in the post-payment work of the visit that's already been provided. Now, payment for physician phone calls or other qualified healthcare phone calls to patients is relatively new. Those were added in March of 2020 as a result of the COVID public health emergency. And they were paid a pretty low rate at that time. Then 2 months later, providers were communicating to Medicare that, hey, these phone calls that we're having are actually taking the place of what would otherwise have been a live face-to-face service with the patient. Maybe it's medication management, for example, or I don't know, medication management's the first one to come to mind, maybe a post-op visit or talking about potential infections. But they were provided to reduce exposure by preventing patients from having to come into the office setting or other healthcare settings. So in May of last year, Medicare increased the payment for these phone visits that were being provided by physicians and qualified healthcare professionals to match the rates that are provided or paid, for office visits. So the office visit code that, corresponds with the amount of time for these 3 telephone visit codes. These are only temporarily covered by Medicare. So I expect that when the public health emergency ends, we are going to see Medicare coverage for these phone visits also unwind. And let's see, so the coverage, we know as of right now, Medicare's rule for 2021 is that coverage for those 3 phone visit services is scheduled to end. Right now in June, this is also kind of an exciting time of year because about a month from now, we should also see a proposed rule for the physician fee schedule in 2022. So I can tell you as of today, Medicare does not plan to cover phone visits after the public health emergency ends, which is looking like 2022 from a federal level. But it's also very possible that in the last 6 months, providers have lobbied and are working to change Medicare's opinion. And we might see something different here in the proposed rule that comes out in the next month or so. And so this is the link to the letter to the governors, if you want to take a look at that, suggesting how long we may expect to see the federal public health emergency in place. Now, for phone visits, the Kansas Medicaid policy is that instead of a physician reporting 99441 or 42 or 43 for their phone call with the patient, KMAP says, gosh, because our bulletins, our policies are allowing you to deliver office visit services via phone for the duration of the public health emergency. Right now, instead of billing these telephone call codes, just bill the regular office visit code that would describe the service and use place of service 02. So KMAP is covering this during the term of the public health emergency, just not using those codes. They want us to use regular office visit codes. They are covered by Oklahoma Medicaid. They're on your fee schedule. So if you go back a few slides, there was a link that would take you to the Oklahoma Medicaid fee schedule. You can pull that up, search for 99441 and the phone visit codes and see the payment rates there. Missouri Medicaid hasn't issued any guidance on the provider phone codes. So they're more likely than not during the COVID public health emergency following policies that are similar to Kansas Medicaid. But I do expect that once the public health emergency ends, Kansas and Missouri Medicaid probably will not be covering these phone call visits any longer either. Kansas.
Michelle,
yes.
I wanted to interrupt you for just a second because we had a question that popped up in the chat.
Yeah, sure.
Yeah, so it says if a patient has symptoms and the doctor, while doing the telephone call, decides that the patient should come to the clinic, what code should you use to document it?
Yes, so when it leads to the decision, let me go back a slide or two here. When it's this last portion of the code that it leads to an evaluation and management service, let's say that day, it sounds like is described in the question. You don't report the phone call visit code at all, or the virtual check-in, or the remote evaluation of images or videos. Instead, that service that you've just provided is going to be part of the payment and part of the pre-service work for the evaluation and management service you end up providing. Did that answer the question, Chris? Or does that look like that answered the question, Christy?
Perfect. Yes, thank you.
Okay, great. So I mentioned these first 3 phone call codes cover phone conversations from a physician or another healthcare professional who's eligible to bill for evaluation and management services. Because these codes, if you were to open up your paper CPT book, they fall in the evaluation and management section of the book. And there are some licensure and scope of practice restrictions on who can provide evaluation and management services. So there is a second set of codes for phone call visits for other healthcare professionals that are not eligible to report evaluation and management services. So those may be our social workers, our physical, occupational, speech language therapists, and speech language pathologists, speech therapists. They look exactly the same other than who is providing the service. So there's a different range of codes for those. So they're not evaluation and management services, but they look and work exactly the same. It just depends on who's providing them. Here's what those codes look like. It's 5 to 10 minutes. 5 minutes being a minimum threshold. You need to document how much time you're spending on the phone with the patient, but they're by professionals who do not report evaluation and management services. These codes, if you were to open your CPT book, are not in the evaluation and management section. They're at the back in the medicine section where other healthcare professionals can choose codes for their services. While these the phone visits, just like the other communication technology-based services, in their description in the CPT book, they're limited to established patients that have seen that provider that's delivering the phone call service or another provider of the exact same specialty in the same group practice in the last 3 years. During the public health emergency, when we're providing a phone service, we are allowed to do that for new patients as well. Once the public health emergency ends, we will revert back to the rule that they can only be provided to established patients. The other thing we need to keep in mind too is that when we are providing e-visits, virtual check-ins, remote evaluations of images or video, or a phone call service, and are reporting those services, when and if that patient, if they're a new patient for these virtual check-in technology-based services, and they eventually come in face-to-face or have a telehealth service that we bill with an evaluation and management code, at that point, they may no longer be a new patient for purposes of reporting an office visit code. They may be an established patient when we're reporting that first office visit or telehealth service that we have with the patient. So keep that in mind too for kind of down the road reporting. So here's what the payment for in this first column, those are for the telephone services by a physician or other healthcare professional who's eligible to bill for evaluation and management services. And you can see the rates for those compared to the codes for phone visits by individuals who are not eligible to bill for evaluation and management services. And there's a considerable difference there. So we want to make sure we're selecting the right group of codes. And again, that hashtag is when it's done in a facility-based setting. So that may be a hospital outpatient department or a physician office that's wholly owned and provider-based facility setting versus your regular office visit setting that is not facility-based, where we would get paid the amount in the line that does not have the hashtag associated with it. All right, I think I ran over 3 minutes last time, so I'll give you that 3 minutes back here during this session. Any questions you have, please feel free. You can enter into the chat now or ask now, but they're also available through the HTRC email address, and we can do a Q&A through that form as well if you're not comfortable asking during our session today. So thank you. I hope that's helpful. Please do look for the communications on the upcoming sessions in July and August for care management services and remote patient monitoring. They've become very popular services with pretty decent payment rates from the Medicare program. And Medicare has said not enough providers are using them. So we hope that education will be helpful in allowing you to use them and be paid for them.
Just to chime in with that, a great presentation, Dr. Marty. The next presentation is telehealth in a hospital setting, including critical access hospitals. So we hope you join us Thursday, June 17th at noon for that presentation, as well as the other upcoming ones.